This lecture will be on the concept of oxygenation. When we talk about oxygenation, we need to remember lifespan considerations. So let's discuss oxygenation in children. The infant's airway is approximately 4 millimeters in diameter, about the width of a drinking straw, in contrast with the adult's airway, which is 20 millimeters. The child's little finger is a good estimate for the child's tracheal diameter and can be used for a quick assessment of the airway size. At birth, the lung tissues contain an estimated 50 million alveoli, which are not fully developed. After 8 years of age, the alveoli begin increasing in size and complexity. The number of alveoli increased to more than 300 million by adulthood. Children under the age of 6 years of age have intercostal muscles that are immature, as well as flexible ribs made of mainly cartilage rather than bone. They primarily breathe with their diaphragm until their intercostal muscles fully develop. Because of their narrow airways, infants and preschoolers are at risk for airway obstruction by foreign objects, as well as infections that can cause edema of the airway or an accumulation of secretions. Example, there is, say for instance, an involvement of 1 million alveoli secondary to pneumonia would be about 4% of the lung for a pediatric client, but only 0.33% for an adult. Therefore, a child can experience respiratory distress more quickly and muscle fatigue can develop more rapidly as a child works harder to breathe. This is a slide that gives a summary of the respiratory differences between adults and children. So take a look at it and compare the child versus the older adult for their differences. Trachea swelling in the newborn versus an adult. If edema, swelling, and/or secretions are present, such as when a child has a respiratory infection, then the condition increases the airway resistance in children because of their narrow airways. During this time, the child must increase the breathing rate in order to maintain adequate oxygenation, thus creating negative pressure in the airways, which further narrows the airways. And if you look at this slide, you will see on the very top where it has the newborn whose airway diameter is 4 millimeters. But if there's just 1 millimeter of swelling, and remember that the swelling goes around the entire diameter, that creates an opening of only 2 millimeters versus the adult with 1 millimeter of swelling. You still have a large amount of an opening there or diameter there that airway can pass through. When we think about oxygenation in the older adult, we have to remember that as adults age, their rib cage may change shapes, causing the rib cage to not expand and contract as well as it used to. The diaphragm also weakens with age, while tissues that support the structure of the airway also weakens, thus allowing the airways to collapse more easily. The nervous system becomes less efficient, decreasing the older adult's ability to control breathing and decreases the cough reflex. Changes to the cough-gag reflex also increases the older adult's risk of choking on food, and the increased incidence of gastroesophageal reflux with age increases the risk of aspiration of food into the lower respiratory tract, leading to aspiration pneumonia. In addition, older adults should be assessed for kyphosis, which is the curvature of the spine, which can often contribute to difficulty breathing as well. Acute respiratory failure, ARF. Acute respiratory failure results from inadequate gas exchange by the respiratory system. We have what we call near match and mismatch. A near match is when there is a near match in the lungs between air movement, which is ventilation, and we represent that with a V, and blood flow, which is perfusion, that we represent with the letter Q, which is needed for adequate pulmonary gas exchange. So again, there's a near match between the air movement and the blood flow. Now, when we have a mismatch, that means the gas exchange is reduced, and respiratory failure can result when either ventilation or perfusion is mismatched with the other in the lung or the lung area. Acute respiratory failure results from either a ventilatory failure, an oxygenation failure, or a combination of both ventilatory and oxygenation failure. And in both cases, the patient will be hypoxic, which means low arterial blood oxygen levels. And we're going to go into great detail on each of these different conditions here. Let's discuss ventilatory failure. Ventilatory failure is a problem in the oxygen intake, air movement or ventilation where the blood flow, perfusion or Q is normal, but the air movement, ventilation or V, is inadequate. There are certain conditions that can cause ventilatory failure. One is a physical problem of the lungs or the chest wall. Two, a defect in respiratory control center in the brain. Or three, poor function of respiratory muscles, especially the diaphragm. When chest pressure does not change enough to permit the air movement into and out of the lungs, then there's too little oxygen that reaches the alveoli, and carbon dioxide is retained, which leads to poor gas exchange and hypoxemia. Now remember, I just said that the carbon dioxide is retained, so that's where the individual is going to have hypercapnia, which means an increase in arterial carbon dioxide level. Your text goes into great detail about what are some extrapulmonary causes, meaning causes outside of the lungs, or intrapulmonary causes, which means, again, causes that have occurred because of something going on inside of the lungs. Now, there's three criteria that have to be met in order for it to be ventilatory failure. One is that the arterial carbon dioxide, or the PaCO2 level, has to be above 45 millimeters of mercury, which gives us that diagnosis of hypercapnia, plus acidemia, which means the pH is less than 7.35, and they must have an arterial oxygen saturation, or O2 sat, of less than 90%. So again, these three criteria must be met for this to be considered ventilatory failure. Now let's discuss oxygenation failure, or gas exchange failure. Oxygenation gas exchange failure occurs when the oxygen intake, or ventilation, or the letter V, is normal, but lung blood flow, or perfusion, or the letter Q, is decreased for some reason. Pulmonary blood is not oxygenated sufficiently. So what are some reasons for this VQ mismatch? It might be that there's impaired diffusion of oxygen at the alveolar level, which is different than just not enough oxygen getting into the lungs. Maybe because the systemic venous blood, or oxygen poor blood, passes through the lungs without being oxygenated and is shunted to the left side of the heart and into the systemic arterial system. Normally, there's less than 5% of cardiac output contains venous blood that has bypassed oxygenation. Or lastly, it might be with poor oxygenation of the pulmonary blood at the alveolar level that even more arterial blood is not oxygenated. And that is when applying oxygen at 100% oxygen, it does not correct the problem. And this is where we're going to be talking about with our acute respiratory distress syndrome. It's called refractory hypoxemia. So no matter how much oxygen you give them, their O2 sat is not going to increase. Again, on a page in your text, it has examples of common causes of this oxygen failure. And just like ventilatory failure, you're going to have some criteria that the individual must meet for it to be oxygenation failure. And that's defined as your PaO2, or the partial pressure of arterial oxygen, is less than 60 millimeters of mercury, and arterial O2 sat is less than 90%. So there's two criteria here for the oxygenation failure. You may have some instances where the individual has a combined ventilatory/oxygenation failure. And this often occurs in patients with abnormal lungs. Say, for instance, they have a history of chronic bronchitis, emphysema, cystic fibrosis, or multiple asthma attacks. And this is where there's decreased bronchioles and alveoli that causes oxygenation failure. Or the work of breathing increases until respiratory muscles are unable to function effectively, causing ventilatory failure. Again, a combined ventilatory oxygenation failure involves poor respiratory movement or hypoventilation and impaired gas exchange at the alveolar capillary membrane level that results in poor diffusion of oxygen into the arterial blood and carbon dioxide retention. You may have a client who is in cardiac failure along with ventilatory failure, and the cardiac system cannot adapt to the hypoxia by increasing the cardiac output, thus leading to acute respiratory failure. And again, like before with the other two, we have those certain criteria. So now for the combination ventilatory and oxygenation failure, that's going to be defined as having a PaO2 of less than 60 millimeters of mercury. That's oxygen failure. You're going to have a PaCO2 of more than 45 millimeters of mercury, and that's the hypercapnia, with a pH of less than 7.35, which is the acidemia, and then the O2 sat of less than 90%. So they have to have all of these things going on in order for it to be able to be defined as a combined ventilatory/oxygenation failure. Let's discuss the assessment of acute respiratory failure. Now remember, you're not going to have just one area of symptoms because they all blend into one another. For example, if you have someone who has hypercapnia, you're going to have someone who looks like they've got hypoxia and acidosis as well. Remember, dyspnea is the hallmark of respiratory failure, but you need to know the difference between dyspnea and short of breath. So say, for instance, you just ran 2 miles, you're short of breath. Whereas dyspnea means you're having difficulty moving air in and out. Dyspnea can lead to shortness of breath due to ineffective breathing and the gas exchange and feel like they're needing more O2. And then you may have perceived dyspnea, where you have perceived difficulty breathing, how breathless the client becomes while performing common tasks. That's where you're going to see like the dyspnea on exertion, or they may have orthopnea. Dyspnea usually leads to use of accessory ventilatory muscles, tachypnea, tachycardia, diaphoresis, anxiety, irregular or gasping breath patterns. Now, when you get ready to look at the slide as well, you've got symptoms that are related to the systemic effects of having hypoxia, hypercapnia, and acidosis. So you do need to know the difference between the symptoms of each here. When we talk about somnolence, remember that sleepiness or drowsiness is a strong desire to sleep, versus lethargy is the lack of energy or tiredness or fatigue or sluggish that causes you to feel sleepy. And then the word obtunded means altered level of consciousness, more depressed level of consciousness that cannot be fully aroused. The more CO2 that accumulates in the blood, the increased amount of acidity in the blood, the pH decreases. And this can lead to CO2 narcosis, where they really feel anxious, have dyspnea, daytime hypersomnolence, delirium with confusion, and then they usually become obtunded. Respiratory acidosis and respiratory alkalosis are caused by changes in the CO2 exhalation, or getting rid of that CO2. When the pH is decreased because of retained CO2, the body tries to compensate initially by breathing faster and deeper, therefore increasing the pH because they're blowing off the CO2, so where the pH becomes more alkaline. But because of the condition, the muscles become fatigued and they get to a point where they cannot blow off the CO2, therefore causing respiratory acidosis. The kidneys then try to retain the bicarb to increase the pH level as a form of compensation if it is for sure chronic respiratory acidosis. That's again when the kidneys try to retain the bicarb to increase that pH level. How do we know that a client needs oxygen? Usually they will experience dyspnea, nasal flaring. You will see the use of those accessory muscles to breathe, pursed-lipped or diaphragmatic breathing. They'll have decreased endurance. Their skin or mucous membrane may have changes as far as their color goes. It may look more pale or pallor or cyanotic. Oxygen therapy is appropriate for the clients with acute hypoxemia. It's used in acute respiratory failure to keep the oxygen arterial level above 60 millimeters of mercury while treating the cause of the respiratory failure. And again, you're always going to have to treat that cause. If O2 therapy does not maintain acceptable PaO2 levels, indicating adequate gas exchange, then mechanical ventilation, invasive or non-invasive, may be needed. The FiO2 is the percentage of oxygen administered, and on a ventilator, it is set at the lowest possible level to maintain a PO2 of higher than 60 millimeters of mercury and an O2 sat of at least approximately 90%. Besides oxygen, what are some additional interventions for acute respiratory failure? Drugs are given systemically by nebulizers or by metered dose inhalers, which may be prescribed to dilate the bronchioles and decrease inflammation to promote gas exchange. Corticosteroids may be used, but their benefit has not been demonstrated. Pain medicine if the client has pain to keep them comfortable. Neuromuscular blocker for optimal ventilator effect, so they don't tend to what we call buck the ventilator. Diuretic therapy and antibiotic therapy may be necessary depending on the underlying condition, because remember, we want to try to treat the cause. We need to help the client to a position of comfort that allows easier breathing, which is again usually in that upright position. Relaxation, diversion, and guided imagery to help decrease the anxiety that's occurring because of the dyspnea that they are having. This is an oxyhemoglobin dissociation curve, and the way you look at this is if you see that we need a PaO2 of above 60 millimeters of mercury, because below 60 millimeters of mercury is oxygenation failure, then to keep it above 60, we'll keep the O2 sats above 90%. And with respiratory failure, the O2 sats are below 90%, demonstrating hypoxemia. So our normal PaO2 is 80 to 100. And again, if you have a PaO2 of approximately 60, you're going to have an O2 sat of 90%. If you have a PaO2 of approximately 50, your O2 sat is going to be about 80%. And again, with PaO2 of approximately 40, you're going to have an O2 sat of 70%. So again, we want to try to keep a PaO2 normal between 80 and 90, 80 and 100, excuse me. Now, I know you've had ABG interpretation in second semester, Nursing 112, but we're going to review and go into a little bit greater detail here and make sure that you totally understand how to read a blood gas. So when we look at the pH, that's going to be used to determine acidosis or alkalosis. The normal, again, is 7.35 to 7.45. Less than 7.35 means they're acidotic. And then the greater than 7.45 means they have some alkalosis going on. We're going to go into great detail as far as ABG interpretation. This slide is using the Rome method, and then the next slide will be using the tic-tac-toe method. I personally only use the Rome method, so that's the one I'm most familiar with, but I will go over these in great detail during the lecture time period, plus there will be a lab that will be devoted to interpreting ABGs. Our main patient goal for someone who has acute respiratory failure is to get a breathing pattern and a blood gas that are within acceptable ranges. So we know that they've got good ventilation and oxygenation there and perfusion. So as far as interventions go, we've talked a little bit about oxygenation therapy, and I have given you, I think, on the folder, the page numbers that will go with oxygenation therapy, and then there's an additional page for actually talking about ventilation as far as using a ventilator goes. But our oxygen therapy, we want to maintain that PaO2 of greater than 60 millimeters of mercury. We want that O2 sat to be greater than 90% at the lowest amount of oxygen concentration that we can give them. So we don't want to give them more oxygen than they really need. As far as positioning goes for acute respiratory failure, that's in that upright position, head of the bed up, so it allows easier breathing unless it's going to be, we're getting ready to talk about acute respiratory distress syndrome with respiratory failure, and then we want to maybe see about alternating a prone position, which is where they're lying on the belly, and the upright position, and we'll discuss that in just a few slides, the rationale why. We want to have energy conserving care. Minimal self-care with no unnecessary procedures when they have the acute respiratory failure going on. And again, the respiratory therapy, the ABG gives us a lot of information, so we need to look at that information and monitor it frequently so we can see if there's improvement, if there's some compensation going on there. Medications, again, through your nebulizer, the MDIs, again, help to dilate those bronchioles, and that decreases the inflammation so they can get that better gas exchange. We've already talked about your analgesics and either antibiotics or diuretics to treat the underlying cause. Positive pressure ventilators, this we will talk more about during lecture. And again, these are ventilators that actually push air into the lungs rather than drawing it in as negative pressure ventilators do. So there is a difference between positive pressure ventilators and negative pressure ventilators. And then we have non-invasive positive pressure ventilators. They provide respiratory support by way of maybe a tight fitting full face mask or a nasal mask or nasal shield, mainly used for these clients with sleep apnea, neuromuscular diseases, or impending respiratory failure, maybe due to advanced COPD, and for those in respiratory failure who refuse to be intubated. It's not used for those individuals with decreased level of consciousness, and this is where one of these types of masks is where it triggers, the trigger prompts the ventilator to deliver a breath. So you'll see this with a lot of these conditions that we've just mentioned. These individuals will have a lot of secretions with a cough. So one of our goals is to have them to have an effective cough with the ability to clear secretions. And some interventions that we can use to help with the thick secretions and to help them to clear those secretions is to mobilize and liquefy those secretions as much as we can. One of the ways is through hydration and humidification. So lots of fluids on board as far as drinking, oral fluids, and humidification, and actually that is through a humidifier. Deep breathing exercises helps to expand those lungs. Chest physical therapy helps to mobilize the secretions that are in the lungs. And then, of course, airway suctioning can be used to help effectively move those secretions. So now we're going to discuss acute respiratory distress syndrome, ARDS, and you are going to hear us refer to this as ARDS. Now, acute respiratory distress syndrome is acute respiratory failure, but it has certain unique features, and those will be discussed on the next several slides. So this is a condition that causes fluid to build up in your lungs, and where the fluid builds up at is in the tiny little air sacs called the alveoli. And that's because fluid leaks from those small blood vessels and collects in those tiny air sacs. And when this happens, that means your lungs can't fill up with enough air. Your blood can't pick up enough oxygen and carry it to the rest of the body. So certain, your organs, such as your kidneys or your brain, might not work the way it should, or they may shut down. The organs may shut down. And ARDS is sometimes life-threatening, but can worsen very, very quickly. So what we need to do is make sure we make a fast diagnosis and treatment as quickly as possible. Now we're going to talk about acute respiratory distress syndrome, or ARDS. Okay, so ARDS is an acute respiratory failure. Okay, so the umbrella term acute respiratory failure is the top umbrella area, and ARDS, acute respiratory distress syndrome, falls under acute respiratory failure. Okay, so with that being said, there are certain characteristics that ARDS, or acute respiratory distress syndrome, has. One is what we call refractory hypoxemia. Okay, we know they're going to be hypoxic, but this is refractory hypoxemia, where there's a decrease of arterial oxygen despite the administration of oxygen at a high flow rate. Even when they're given 100% oxygen, that O2 saturation just does not come up. So that is the one cardinal or hallmark sign of acute respiratory distress syndrome, or ARDS. There's also compliance in the elasticity of the lungs. That's their ability to expand. Dyspnea is again a cardinal sign or hallmark sign of acute respiratory failure, part of the respiratory failure itself. Okay. Non-cardiac means that the edema that has collected in the lungs has absolutely nothing to do with the heart not performing or pumping properly. You also see some whiteout on a chest x-ray, or we actually ends up seeing that it's like a fine type of broken glass type appearance on the chest x-ray, and it may or not be seen as an early sign. ARDS has a rapid onset and is due to extensive lung tissue inflammation and small blood vessel injury that affects the organs, causing them to malfunction. And again, the main trigger of ARDS is a systemic inflammatory response no matter what the cause of the ARDS is. And again, it occurs usually after an acute lung injury, or you may see us have it as ALI, in people who have no pulmonary diseases as a result of maybe sepsis, burns, pancreatitis, trauma, transfusions. Again, other terms you might hear for ARDS may include adult respiratory distress syndrome or shock lung. But again, despite their different causes of the acute lung injury, the trigger is a systemic inflammatory response. Again, ARDS, or acute respiratory distress syndrome, is a type of a respiratory failure. It's the most severe form of hypoxia, acute lung injury, which results in respiratory failure related to, again, non-cardiogenic pulmonary edema. Sepsis is the most common cause of ARDS, and sepsis due to a pulmonary cause carries with it the highest mortality as compared to other causes of ARDS. When we talk about some additional causes, again, we've said it's a systemic inflammatory response occurs due to an acute primary insult, which can be what we call direct or indirect. Inflammatory cellular responses occur, which releases this chemical mediators that damages the alveolar capillary membrane. And this damage develops rapidly over, often within 90 minutes of period of time, of the systemic inflammatory response, and usually within 24 hours of the initial, what we call insult. Damaged capillary membranes allows plasma and blood cells to escape into the interstitial space, where increased interstitial pressure and damage to the alveolar membrane occurs, and then fluid is allowed to enter the alveoli through the blood-gas barrier. Within the alveoli, the fluid dilutes and inactivates that surfactant. Without normal surfactant, the tissue surrounding the air sacs or the alveoli in the lungs sticks together because of the surface tension after exhalation, causing the alveoli to collapse. And this inflammatory process damages surfactant-producing cells as well, leading to a deficit of surfactant, which increases the alveolar surface tension and the alveoli collapse, and that's called atelectasis. Now, there's a difference between pneumothorax and atelectasis. A collapsed lung happens when the air enters into the pleural space between the lung and the chest wall. And if it's a total collapse, then it's called a pneumothorax. If it's a partial, only a part of the lung is affected, it's called atelectasis. The lungs then become less compliant and gas exchange is impaired. And as the syndrome progresses, hyaline membranes form, which is tissue made up of protein and dead cells that line the alveoli, and then this further reduces gas exchange and compliance. And then finally, you get this fibrotic changes that occur in the lungs, and surface area for gas exchange is reduced. Hypoxemia becomes that refractory, remember, that we talked about, where O2, no matter how much O2 you give them, it doesn't help bring up the O2 saturation, or resistant to improvement with supplemental oxygen, and the PaCO2 rises as diffusion is further impaired, and that's where they get that hypercapnia. As ARDS progresses, tissue hypoxia becomes significant and metabolic acidosis develops. Then both carbon dioxide exchange and the oxygen exchange becomes impaired, leading them to a combined respiratory and metabolic acidosis. On this slide, you'll see what happens during the initiation of acute respiratory distress syndrome, and then you have the onset of the pulmonary edema. And remember again, the pulmonary edema is non-cardiogenic, has absolutely nothing to do with the pumping of the heart being insufficient that causes that edema to occur. So the bottom picture on this slide talks about how there's decreased alveolar compliance, there's atelectasis, and then that's where you have the fluid-filled alveoli, which interferes with the gas exchange across the alveolar capillary membrane. Now, the blood oxygen level falls because think of this, the oxygen molecule can't swim, so it can't get out to the outer edges to the alveoli, whereas the carbon dioxide does. It diffuses more readily than the oxygen. So again, think of oxygen not being able to swim, whereas the carbon dioxide does. So that's where you have the buildup of the carbon dioxide in that hypercapnia there. Okay, then when you talk about the end-stage ARDS, again, that's where, because the CO2 cannot diffuse across the hyaline membrane, the CO2 level begins to rise, the PO2 level begins to fall, and that's where you're going to end up getting your respiratory acidosis. And again, if you don't have any of that respiratory support there going on, you've got respiratory failure that's going to develop. So a good way to remember ARDS is using the mnemonic ARDS, A standing for atelectasis, okay, and that's usually because of the S at the end, the surfactant cell damage. But you have R, which is that refractory hypoxemia. So again, no matter how much oxygen you give them, their O2 sat is not going to increase. And then, of course, that decreased lung compliance for D, and then the surfactant cell damage for S. What are some risk factors for ARDS? Direct insults and indirect insults. And remember, think of the word insult as being injury. So what kind of injuries could they be? If they're a direct insult, that means they're injuries that arise in the lungs. They directly involve the lungs. The source of the lung injury is the lung. So these are things such as your pulmonary infection, aspiration of gastric contents, inhalation injuries, embolism, some lung contusions, like there's a pulmonary embolism and pulmonary contusion. Let's talk a little bit about the near drowning and what the difference is between saltwater versus freshwater drowning. When you have saltwater drowning, it's believed that the hypertonicity, okay, so the high content of salt in the salt water causes plasma to be drawn into the pulmonary interstitium area and alveoli that leads to massive pulmonary edema and hypertonic serum electrolytes, okay? Because the high salt content in the lungs prevents water through osmosis from crossing the membrane of the capillaries. So instead, it causes blood and water from the bloodstream to enter into the lungs because, again, the tonicity is higher in the lungs, which again causes the pulmonary edema there. Okay, so the lungs more or less fill up with water instead of air. So when we talk about fresh water, it almost has the opposite effect as the aspirated hypertonic solution. So let's talk about fresh water. Okay, it has a low salt content that allows water to cross the membrane of the capillary walls and be absorbed into the bloodstream. So when this happens, this leads to a volume overload and a dilutional effect as far as the serum electrolytes go. So again, they still have water in their lungs, but again, there's a little bit different because the high salt content for the hypertonic solution of the salt water, it pulls even more fluid and it pulls it out of the blood plasma, whereas in this case, the hypertonic solution, it allows the water to cross the membrane and dilute the plasma that's in the blood. And so again, you have the dilutional effect of the serum electrolytes. Then we have the indirect insults. The indirect insults indirectly involve the lungs, a process that can cause inflammation outside of the lungs. So the tissue area outside of the lungs is the source and not the lungs themselves. So you may have, for instance, body, not lung, sepsis, body sepsis. And remember, sepsis is the most common cause of ARDS, especially if the bacteria is a gram-negative rod bacteria, because this type of bacteria is very, very hard to treat, and the inflammation damages the alveoli capillary membrane, leading to more fluid leaks in the alveolar sac. Maybe due to chest wall trauma, okay? Again, not the lungs, but the chest wall. Might be due to pancreatitis from GI infections. Again, that's acute pancreatitis. Might be due to drug overdoses like your narcotics or tricyclics or antidepressants, because they can again rapidly cause vasoconstriction and bronchoconstriction of the bronchiole there, okay, which is connected to the edema. Transfusion-related acute lung injury. Again, you're going to see it's called TRALI, T-R-A-L-I, and it has a sudden onset within 6 hours of a blood transfusion. Again, without any kind of cardiac problems, they'll develop infiltrates on the chest X-ray. And it's associated with the activation of the inflammatory response that's caused by the recent transfusion of the packed red blood cells or platelets, or it may be fresh frozen plasma. Most common causes of ARDS in pediatric clients are pneumonia, aspiration, major trauma, near drowning, and system infection. Children who are immunocompromised are at increased risk as well, though the incidence of pediatric ARDS is low and lots of times it goes undetected. Age over the age of 70, because the age-related changes in respiratory physiology, remember, including the loss of elastic tissue, the increased chest diameter, the decreased muscle strength. Older adults are significantly more likely to die from multi-organ failure, MOD, or multi-organ system dysfunction, than any other complications, especially the elderly who are immunocompromised or who have chronic liver failure are at highest risk for mortality. If they smoke or drink alcohol, abuse alcohol, that may increase their risk for ARDS as well. And believe it or not, females are at a higher risk than males. So what we want to do is we want to prevent any type of these injuries, direct or indirect, and preventing the risk factors for ARDS and initiating timely interventions. Remember, again, we talked about sepsis, and that usually does lead to the multi-organ system dysfunction of the kidneys, the liver, the GI tract, the central nervous system, the cardiovascular system, and all of these can lead to death with ARDS. And what we want to do is, again, halt the process before sepsis or the multi-organ dysfunction occurs. We're going to talk about the different stages or phases of ARDS, and some of these have additional terms to them as well as far as names of them. So for instance, this exudative phase, you may hear it as being the initial phase of ARDS. And this is again where the edema starts to occur. It occurs approximately 24 hours after the injury, okay, where the protein-rich fluid tends to leak into the interstitial spaces through onconic pressure, and that draws the fluid in that causes that pulmonary edema. And typically at first, I want you to remember that it starts out as respiratory alkalosis, and then as the body tries to compensate, it's going to turn into respiratory acidosis. But again, in that exudative phase, the early stages or changes of dyspnea, tachypnea, again, that results from the alveoli becoming fluid-filled and from pulmonary shunting. Again, that's where some of the blood bypasses the lungs and gets back into the bloodstream unoxygenated and then causes the atelectasis. And this response phase may last up to 1 week. Then you have the proliferative phase, or the proliferative phase, and that's that body's attempt to repair. And this can occur within 3 days and can overlap with the exudative phase of inflammation there. This is where you're going to have increased lung injury that leads to pulmonary hypertension and fibrosis, which is again just scarring and thickening of the tissues between the air sacs. The body attempts to repair the damage, and increasing lung involvement reduces gas exchange and oxygenation, and this is where your multi-organ dysfunction syndrome can occur. Then last, you have your resolution phase, and that's again can be called the fibrotic stage. This phase usually occurs after 14 days. You have resolution of the injury, whatever the injury was that occurred, but the final fibrotic stage is not a universal outcome in ARDS, but is linked with increased mortality and prolonged mechanical ventilation, as someone being on the ventilator. So whether or not the fibrotic stage is reached may be related to the degree of damage to the membrane and the formation of those pro-fibrotic or fibrotic mediators. So that is the determining factor in this case. When you look at the chest X-ray on the left side, that's an actual normal chest X-ray. You see the darkened areas that actually outlines the lungs, and you see kind of the white in the middle. That's actually the heart. the outline of the heart area, and then of course down below that's the kind of the diaphragm area. So compare the one on the left to the right, and you see that with someone who has ARDS, acute respiratory distress syndrome, it gives it more of a hazy kind of look, or what we call a whiteout, or your book actually describes it as ground glass appearance of the lungs. So that's what it's going to look like when it actually is full of fluid in the lungs. Here are some additional chest x-rays for you to view that shows the early and the late stages. So when you look at that early stage or early phase of acute respiratory distress syndrome, you're going to see some of those interstitial changes beginning, and you'll have what we call patchy infiltrates. So again, it'll kind of be in areas of patches, okay? And then when you get to the later stages, as you go on, you're going to have more bilateral and diffuse alveolar and reticular opacification, to where it looks more opaque, as we call it. And then you eventually at the very end, you have that total whiteout, as you saw in the previous x-ray. Now, when we talk about what the breath sounds are going to sound like, when we talk about in the early stages, the lungs are going to have decreased breath sounds. So you can kind of hear, understand the reasoning behind that, because again, you have those patchy infiltrate areas that aren't being able to oxygenate proficiently. And then in the middle stages of ARDS, the patient may have what we call bibasilar crackles or even coarse crackles, again because of the fluid. And in the late stages of ARDS, if the disease has been left untreated, the patient may have bronchial breath sounds or little gas exchange with no breath sounds at all. So that's what they would sound like as the chest x-ray progresses from one to the other. Here are some additional diagnostic tests that we may do to decide if it is ARDS or not. ABG analysis determines the low levels of oxygen in the blood, but gives us also some other information as well. In addition to hypoxemia, the O2 sat arterial blood gases often initially show a respiratory alkalosis, and that's normally from hyperventilation in the early stages of ARDS. Now, it's a little different with the ARDS that occurs in the context of sepsis. They may end up having metabolic acidosis with or without respiratory compensation. And the reason why this is with hypoxia, this causes tissue ischemia, so not enough oxygen to the tissue, and lactic acidosis occurs when that oxygen supply to the tissue is too low. So the end point is anaerobic breakdown. So the end point is anaerobic breakdown of the glucose in the tissue, which again is what causes that metabolic acidosis in the context of sepsis. But as the condition for either one continues, it progresses with the work of breathing, it increases, the partial pressure of carbon dioxide begins to rise, and therefore it goes from respiratory alkalosis and goes on into respiratory acidosis. So the end result there is the respiratory acidosis. Blood tests such as complete blood counts, blood chemistry, and blood cultures help us to find the cause of the ARDS if it's an infection going on, as well as sputum cultures, again, determine the exact cause of the infection of a pulmonary infection, if that is the cause. And again, remember we always want to find out what the cause is and treat that cause. That's our number one goal, to try to halt the progression of the ARDS. Pulmonary function test reveals if there's decreased compliance and decreased lung volume because of the decreased level of surfactant. Lungs can't expand or hold as much air. Then your plasma B-type natriuretic peptide, which is the BMP, if it's less than 100 pg per ml in a patient with bilateral infiltrated hypoxemia, then that does favor ARDS or acute lung injury, and we now know that it is not cardiac related if that level is less than 100. As with any assessment, we need to identify our clients that are at risk. So remember, we talked about direct or indirect insults to the lungs, those individuals who have had those injuries and are at high risk. Then smoking, exposure to high levels of pollutants over the age of 70. But remember, age alone does not make them at a higher risk. Immunocompromised, chronic liver failure, those are some additional risk factors. Then when you do the client interview, ask about any previous respiratory problems. Do they have a history of asthma, emphysema, COPD? Any previous recent respiratory illnesses? Any recent direct or indirect injuries to the lungs, like in the past previous 3 to 4 days? Respiratory assessment. We need to assess for increased work of breathing, their respiratory effort. Do we hear any noisy respirations, diminished breath sounds to indicate atelectasis? Are they having any dyspnea, tachypnea, intercostal or substernal retractions? Are they using any accessory muscles there to breathe? Abnormal breath sounds are not heard on auscultation lots of times because the edema occurs first in the interstitial space and not in the airways. So that's again why the air sounds or breath sounds can be normal at first. Check for any altered core body temperature, any abnormalities there. They may have a temperature elevation early in the course of ARDS, and then those clients usually have a better outcome than those who have hypothermia. Skin assessment. Cyanosis develops and may not improve with oxygenation. That's again that refractory hypoxemia. Are they diaphoretic? Mental status changes. Do they have changes in their sensorium with decreased mentation? Are they anxious? Do they feel confused? Are they agitated? Are they restless? Anybody who is restless, one of the first things you think of, are they having an airway problem or oxygenation problem? And then your cardiac assessment. They will have tachycardia, which will cause a decreased cardiac output. So here's a recap, more or less, showing and talking about the clinical manifestations. Again, look at your baseline laboratory data and diagnostic tests to see if there is any kind of cardiogenic cause that could not make it be ARDS. Or again, is there any kind of infection, major infection going on? But with their clinical manifestations, again, we've talked about they're going to have that dyspnea and tachypnea. Again, initial clinical manifestations of ARDS will typically develop a full day or two following that initial insult. So we do need to rely on these baseline laboratory data as well as diagnostic tests. Initially, the breath sounds may be clear, but remember again, the reason why they are clear is because it's the interstitial edema and not edema or fluid in the lungs at first, okay? Laboratory data results will be consistent with presenting illness, with the exception of that direct pulmonary illness. A chest x-ray will often show that the lungs to be clear of infiltrates and ABG values may be within the normal range, so don't let that confuse you. Let's see, as the breath sounds initially may be clear, later on they may have rales or rhonchi. As progressive respiratory distress develops, the client's respiration rate, intercostal retractions, and the use of accessory muscles of respiration will all increase. Then the X-ray, chest X-ray, will exhibit some minimal scattering interstitial infiltrates or demonstrate diffuse and extensive bilateral infiltrates to where it even gets to then the white out, which is that hallmark sign of ARDS on a chest X-ray. Cyanosis will develop but will not improve the oxygenation administration because of, again, that refractory hypoxemia. And then we've already discussed about the mental status changes that will include increased agitation, confusion, lethargy as the failure progresses. For each of these nursing diagnoses, I want you to think back of what we've already talked about and be able to understand why they might have ineffective airway clearance or ineffective breathing pattern, or for instance, again, the impaired gas exchange because of the interstitial edema and decreased lung compliance. Decreased cardiac output, we just talked about on the last slide, or slide before last, about the tachycardia that causes that decreased cardiac output. And again, any kind of mental status changes or anxiety, risk for acute confusion or risk for activity intolerance, again, because they have that lack of oxygen to the major organs and tissues, okay? And again, the risk of infection is mainly because of if they are put on a mechanical ventilator, that's a source of infection even to the lungs there. So our main goal here is to maintain a patent airway, which means that we may have to do that chest PT, physical therapy, to loosen secretions and move them into larger airways for removal by coughing or by suctioning. Make sure we are adequately hydrating them to help liquefy those secretions, and again, suction as needed to maintain that patent airway. Many interdisciplinary team members are necessary when caring for a client with ARDS. Pharmacy. Unfortunately, no drugs have been proven to be effective in preventing or managing ARDS. You more or less have to manage the symptoms and take care of them that way. Supportive care is utilized with agents that include corticosteroids. These corticosteroids are used later with ARDS to improve oxygenation and lung mechanics when the fibrotic changes occur. Then you have neuromuscular blocking agents. They may be necessary to help with intubation and or to keep the client from what we call bucking the ventilator. Rocuronium is a short-acting neuromuscular blocking agent that helps to facilitate the insertion of the endotracheal tube, and it's used along with succinylcholine, which causes paralysis of the diaphragm by relaxing the skeletal muscles. So both of those are used whenever they're going to intubate a patient. Pancuronium bromide is a longer-acting neuromuscular blocking agent, so that's used routinely throughout every day to help the client from bucking the ventilator. These meds are thought to decrease inflammation as well, oxygen consumption and cardiac output. Nitric oxide, inhaled nitric oxide, is a selective pulmonary vasodilatator, so that's supposed to help improve oxygenation via vasodilatation of the ventilated part of the lung, resulting in decreased shunting and improved ventilation perfusion matching. Surfactants may be used, again, to help keep those lungs from collapsing. And beta-adrenergic agonists, they help to increase the transport of sodium across the alveolar epithelial to improve the edema clearance there. And then, of course, antibiotics are used to treat the cause if the infection is a cause, and then the use of diuretics. Respiratory therapy. They may need that chest physical therapy. And of course, we've talked about the mechanical ventilation with the endotracheal tube, especially when that refractory hypoxemia occurs, when there's no other way to get oxygen to the lung out to this alveoli area. You do have to end up doing mechanical ventilation. And that also promotes sodium and water retention as a result of its effect on the cardiac output. Renal perfusion is decreased, which stimulates the renin-angiotensin-aldosterone system, also causing a retention of sodium and water. And then you're going to see that a lot of patients with ARDS, and they're on the ventilator, they're going to use what we call PEEP, positive end expiratory pressure, or continuous positive pressure airway, which is CPAP. PEEP is usually started down low, about 4 centimeters of water, and is increased to keep that oxygen saturation adequate. Though a side effect of PEEP can be a tension pneumothorax, and that's when air is trapped in the pleural cavity under positive pressure, and it kind of displaces those mediastinal structures and can compromise cardiopulmonary function. So we need to keep an eye on the location of the trachea and assess lung sounds hourly. The respiratory therapist is the individual that draws the blood gases most of the time, and it also does the suctioning if endotracheal tubes are needed. Nursing, typically we will alternate from a prone positioning to the head of the bed being elevated, and this helps to move secretions from other fluid-filled areas and helps to improve that atelectasis. Conservative fluid therapy, which involves smaller amounts of fluids infused along with the use of diuretics to maintain that fluid balance. But we do have to continue to do very careful intake and output and daily weight monitoring because, again, we are watching that fluid therapy there. Extracorporeal membrane oxygenation, that's called ECMO, ECMO. That's a heart-lung bypass machine. And then lastly, nutritionists. Clients with ARDS are at risk for malnutrition, so total parenteral or enteral nutrition or enteral tube feedings may be needed after nutritional analysis is made by a registered dietitian. Typically, they say a decreased carb diet helps to reduce inflammation, and inflammation is one of those things that we need to try to reduce in someone with ARDS. Here are some additional independent interventions. And again, by independent interventions, that means we do not need a doctor's order to carry them out. So turn the client as often as possible. This helps to increase ventilation and perfusion to all areas of the lung. It also helps to prevent skin breakdown. Provide passive range of motion exercises. This helps to prevent contractures. Conserve oxygen and limit consumption by spacing out all activities, limiting interruptions to enhance rest, and providing a quiet environment. We need to assist alleviating fears and anxiety that the patient or their patient families may have by acknowledging their fears without providing false reassurance. Explain the critical care environment and the technology. Maintain open communication with the patient and their family. Answer questions and provide methods for the client and family to communicate, such as maybe a slate board, because remember, an individual patient who is intubated cannot speak. And provide complete hygiene, and this does include mouth care as needed. There will be a supplemental oxygen delivery modalities PowerPoint that will be separate, so you will want to review that PowerPoint. But on this slide, we are going to talk about oxygen delivery using the FiO2, which FiO2 again means fraction of inspired oxygen. So that's how much oxygen are they actually getting. We always want to go from the least invasive to the most invasive. And we always want to set that FiO2 at its lowest possible level to maintain a PaO2 of higher than 60 millimeters of mercury and an O2 sat of approximately 90% or higher. So when we put on oxygen via a nasal cannula, the patient's getting oxygen plus room air, okay? And again, FiO2 is a fraction of inspired oxygen. At room air, the client's getting an FiO2 of approximately 20 to 21%. If we were to put on 2 liters per minute per nasal cannula, the client would be getting about 28% of fraction of inspired oxygen. At 4 liters per minute per nasal cannula, the client's getting about a 36% FiO2, and at 6 liters per minute per nasal cannula, the client is getting about a 44% FiO2. Now again, remember, we want to know that if it's greater than 4 liters per minute, it does require humidification, and usually we will use sterile water for that humidification. We don't usually use the simple face mask or Venturi mask with ours because you don't know exactly the amount of O2 that can be delivered, or if they can tolerate a nasal cannula, then they need to use a more advanced system. When talking about the Venturi mask, it delivers an FiO2 of approximately 24 to 50%. This allows the PO2 to be titrated, thus minimizing the risk of CO2 retention or CO2 narcosis, especially in patients with COPD, because it's mixed oxygen with room air, and it is more accurate and consistent FiO2 using the Venturi mask, especially with someone who does have COPD. Now, a 100% non-breather mask is best used when you need to bring the O2 sat up quickly without resorting to intubation. So settings of 10 to 15 liters per minute is usually the settings. The mask essentially keeps the client from breathing room air, so it's as close to 100% FiO2 as possible. Short-term rescue therapy is needed. If short-term therapy is needed, then again, the simple mask is used, especially for no more than a few hours without addressing the need for a negative pressure ventilation versus intubation, or a rapid correction of the underlying cause of hypoxia. Now we go from a BiPAP to a CPAP, and again, these can be used with your ARDS individual. A BiPAP is a bi-level ventilator, provides inspiratory positive airway pressure as well as airway support during expiration. So it's a tight-fitting mask with 3 different modes. You have spontaneous breathing, timed mode where pressure supports breaths are delivered at a predetermined rate, and a spontaneous timed mode in which the ventilator switches to time mode if spontaneous breathing falls below a preset rate. Okay. So we have CPAP also, and CPAP is a continuous positive airway pressure with inhalation and exhalation, and it delivers a set positive pressure, okay, with inhalation and exhalation. It helps to open those collapsed alveoli. So again, we start out with the CPAP and then the BiPAP, but if that doesn't work, we may need to do mechanical ventilation with PEEP. PEEP is positive end expiratory pressure. With PEEP, a positive pressure is maintained in the airways during exhalation and between breaths, and it keeps the alveoli open between breaths, which improves that VQ relationship and diffusion across the alveoli capillary membrane. Maintaining open airways and alveoli enhances gas diffusion and reduces that VQ mismatch. This reduces hypoxemia, allows use of lower percentage of inspired oxygen, and PEEP is often necessary in order to prevent collapse of the alveoli, especially during expiration, and promotes oxygenation. Now, the PEEP is usually the end results of what we use on clients with ARDS. Mechanical ventilation does not cure acute respiratory distress syndrome. It simply supports respiratory function while the underlying problem is identified and treated. If someone has an endotracheal tube placed, we need to monitor the mechanical ventilation. Remember, mechanical ventilation promotes sodium and water retention. As a result of its effect, you're going to have a decreased cardiac output. Electrolytes are drawn frequently, and IV infusion is needed, but we don't want to overload the individual. We need to check for renal perfusion because it is usually decreased, therefore stimulating the renin-angiotensin-aldosterone system to retain sodium and water. We need to monitor their BUN and creatinine levels as well as their glomerular filtration rates to make sure that their kidneys are working properly. We need to do a perfusion assessment, check their peripheral pulses, do a skin color assessment, check cap refills. If an endotracheal tube has become dislodged, the client will have a decreased cardiac output, therefore have a cap refill greater than 3 seconds. Need to do a neurological assessment, do a mental status, check their level of consciousness and orientation due to electrolyte imbalances, and mainly it's the sodium because of the sodium retention. ARDS clients will have a pulmonary wedge pressure of less than 18 millimeters of mercury, and that means it is a non-cardiac issue going on. So some hemodynamic monitoring may be necessary. We need to do an intake and output again to make sure that those kidneys are being perfused adequately. Daily weights are used to monitor fluid status. Nutrition, just think the individual that has an endotracheal tube in place prohibits them from eating. So we may need to place an NG tube in, a gastrostomy tube, or jejunostomy feeding tube for enteral nutrition. A jejunostomy tube reduces the risk of regurgitation and aspiration. We may need to continually administer those neuromuscular blocking agents, especially that pancuronium or pavilon, because it induces paralysis and suppresses the client's respiratory effort to the point of apnea, allowing the mechanical ventilator to take over the work of breathing for the client and to relax those skeletal muscles, which improves chest wall compliance. It has no sedative effect, but a sedative or analgesic should be prescribed as an adjunct to pancuronium. This medicine does have an adverse effect of increasing production of respiratory secretions, so they may need to be suctioned more frequently. None of the neuromuscular blocking agents affects the mental status. We discussed a little bit about the endotracheal tubes, and that can be placed in through the mouth or through the nose, one of the NURs, and the tracheostomy tube, which is a surgical procedure. But both of these routes are artificial ways used to maintain a patent airway and provides a means for secretion removal and provides ventilation and oxygenation. Remember that endotracheal tubes are short-term, whereas tracheostomy tubes are used if an artificial airway is needed for longer than 10 to 14 days. It's performed for long-term to prevent the vocal cord damage that an endotracheal tube could cause. Placement of an endotracheal tube is a fast and easy way to establish an airway and many times is performed on an emergency basis. Advanced practice nurses and nurse anesthetists can intubate, but different states have different guidelines for others who can also intubate. It's passed through the epiglottis and the glottis, so the client is unable to speak while the tube is in place. Note markings on the tube to ensure proper position is maintained, so make sure that it has not slipped out. And there are things that we need to do as far as patient care and interventions when a client has endotracheal tube. For instance, establishing an alternate method for communication, providing good oral hygiene, reposition the tube from side to side, and suction as needed. Like I said in an earlier slide, a tracheostomy is a surgical procedure. And as you see on this picture, it is actually inserted into the larynx through a hole, okay, that is made. And it also has a cuff that holds it into place. Okay, when a client breathes through a trach, air is not filtered or humidified as it is when it normally would go through the upper airway. So therefore, a tracheostomy tube will require a mist collar to provide that humidification that's needed. And there are decreased long-term risk with a tracheostomy tube as opposed to an endotracheal tube. Nursing managements for artificial airways, and in this case, we're going to be talking about a tracheostomy tube. We always want to check placement. Checking placement includes listening to the client's lungs because you want to be able to see if all lobes of the lungs are being ventilated adequately. We want a suction for airway clearance in case there's any kind of mucus plugs, because lots of times with the trachs you have a tendency to have more mucus build up. Auscultate those lung sounds at a minimum of every 4 hours. And again, the trach will need some sort of humidification. We want to maintain that cuff inflation to make sure that the tracheostomy tube stays in place. Establish alternate methods for communications because, again, they cannot speak with the tracheostomy tube in place. And we always need to remember to assess for adequate gas exchange and oxygenation. Several complications can occur with a tracheostomy tube. One could be that there's improper tube placement, so it's not placed in the appropriate area, so it's not ventilating all lobes of the lung. Improper tube stabilization, that could be from even a cough or a sneeze could make it come out if it's not properly stabilized. There could be a cuff leak that could cause this improper tube stabilization, so therefore the cuff is not keeping it in place in the appropriate area there. Or it could be due to an aspiration, a complication could be, usually because of an obstruction. And the obstruction is usually a mucus plug that can be then aspirated, which then can lead to atelectasis, which then can lead to infection. So these are some complications that can occur.